vaccine candidates. And to help me out with the moderation for tonight's session, I have Dr. Venkata Mahesh Alla. He's a practicing general cardiologist in Omaha. He's an alumni of Osmania Medical College and did his training in PGI Chandigarh. And after that, he came to United States, did his internal medicine residency and cardiovascular fellowship in Creighton University, Omaha, Nebraska. And since 2012, he has been a faculty there. He's board certified in internal medicine, cardiology, nuclear cardiology, CT tomography, and adult echocardiography. He has received numerous teaching awards and authored a number of articles in peer-reviewed journals and textbook chapters. He has been a past president of Nebraska Iowa Physicians of Indian Origin. Thank you, Mahesh, for joining for the moderation. We'll go straight ahead for the first topic. We have Dr. Amber D'Souza. Thank you, Dr. D'Souza, for joining. She's a professor in epidemiology in Johns Hopkins Bloomberg School of Public Health. She did her master's in University of Wisconsin-Madison, did her MPH in University of Texas Health Science Center, PhD in Johns Hopkins Bloomberg School of Public Health in 2007. And she received numerous honors and awards, cited thousands of times for her publications, member of American Dental Association Oral Cancer Guidelines Committee and advisor, and a member of NIH National Cancer Institute HPV Vaccine Trial Working Group. With that, Dr. D'Souza, please take over. Thank you for joining again.
Sure. Good evening, everybody. I'm going to share my screen so you can see my slides. Are those visible, Sujit?
Yes, yes.
Great. Let me see when I go into slideshow. I have two screens, so it's sometimes, I think I'm sharing the wrong screen now. Hold on. Whoops, let me just make sure I share the right screen with you. Okay, is that working now?
Yes, yes.
Great. Good evening, everyone. I'm an infectious disease epidemiologist at Johns Hopkins, and I'm going to give a brief overview of some of the epidemiologic aspects of what we know about this new coronavirus and COVID, and then welcome any questions that I can help with. So as background, some of the terminology can get confusing. There are several different types of emerging coronaviruses that you might have heard about in the past, like SARS and MERS, when this new coronavirus emerged because of its similarity to the previously identified coronavirus that causes SARS. They named it SARS-CoV-2, which is the name of the infection, and they called the disease that results from this infection COVID. So when people say COVID, they're talking about the clinical condition, but the infectious agent is SARS-CoV-2. So when we talk about what we know so far, which is, as was mentioned, changing quite a bit, but we do have initial models of the transmission timing that suggest most of these infections are transmitted within a week of when the person becomes infected, but sometimes it is up to 2 weeks, and that is why the quarantine suggestions are for 2 weeks. Further studies suggest that quite a bit of the transmission, probably around a third of the transmission, happens pre-symptomatically, so before people are exhibiting symptoms. But again, this is quickly emerging and we still need more data, so these initial estimates might be off. This is US data on testing, and we saw that in the beginning, a very high proportion of people who were getting tested were positive, around 15 or 20%. But as we have ramped up our testing, that proportion has decreased, which is good because it suggests that we are identifying more cases. So currently in May, around 5 to 10% of people getting tested nationwide were positive. And if we look at data that's just from the clinical laboratories, again, we see that there was a higher proportion of positivity, but it's come down now to around 5% of people being tested. And this is from March 8th to June 6th, this data. So if we look at symptoms of infection, we know that there's a constellation of symptoms, and not everyone is presenting with any single symptom, but with 2/3 of patients, so a high proportion, are having some change in smell or taste. But only 1/3 of patients are reporting a severe change in smell or taste. And some, of course, have no change at all. Other frequent symptoms include fatigue, a dry or productive cough, and fever are all common. But again, none of them are ubiquitous in all patients. Modeling of infectiousness suggests this is looking at, and again, these are models, so the data is growing, but we're looking here at number of days from when the person becomes infected and how many people they are transmitting to. So R0 here is a measure of transmission to other individuals, and this is to show that people who are pre-symptomatic, they're more likely to be going out, to go to work, to be mixing around with people, and therefore each pre-symptomatic person is spreading to more people than once they're symptomatic and home in bed and just coming in contact with fewer people. So this is a model of the distribution of what they think the R0 looks like, with a higher spread during the pre-symptomatic phase than the number of individuals that are getting infected during the symptomatic phase here. I wanted to share some nationwide data on the number of cases, and this is, updated as of the most recent data. What you see here is the geographic distribution of cumulative cases. So, of course, we know about outbreaks in select cities like New York, but this helps to show that there are very few locations nationwide that are truly unaffected, while the outbreak has been much heavier in some settings than others. If you look here at the number of cases, the locations that are yellow or light green are few. So most locations have now had at least 5,000 reported cases, most states. And many states are now in the light blue or dark blue category, having had at least 20,000 cases in that state. If we look at it as an epidemiologic curve with new cases by day, we see the sharp increases early in the epidemic before we put social distancing measures in place, and then we see the plateauing and general decrease, but it's not the level of decrease that we, of course, want to see in an epidemiologic curve. You can see where the cases are now, and while it is better than it was a month or two ago, these case numbers are still concerningly high. I wanted to present a global perspective, although I know I was asked to speak on the US epidemic. This is just to show by region the number of cases. So you can see the Americas are in yellow here, and we do constitute a large proportion of the number of cases that have been diagnosed and reported so far. But you can see increasing numbers in some other regions, including in blue, the Southeast Asian numbers, and in purple, the Eastern Mediterranean numbers that have been increasing over the past month of May into June. The European numbers shown in red, of course, show that very high number that was occurring in March or April, but have much lower numbers in May and June. Now to turn to hospitalization. So thinking about our more severe cases, these are cumulative confirmed COVID-associated hospitalizations. We know that we have individuals who we believe have COVID who either have false negative tests or are not tested at all. So these are likely underestimates, but looking at our confirmed cases of hospitalization, these numbers show the rates by age. I actually have to move my screen. Here we go, so I can see. So the cumulative US hospitalization rate is 73 per 100,000, which is actually 0.07% of all Americans have been hospitalized, which is really high, given that this is, an infection we had not heard of in last year, in 2019. to think that already we are approaching 0.1% of all Americans being hospitalized for this condition is really quite stunning. Looking at those cumulative rates of hospitalization by age, you of course see the very strong increases with a higher rate among older individuals, but it does drive home that this is not a condition only among, while we've had certainly mortality and hospitalization are much higher among older individuals. You can see 50 to 64-year-olds here have around half the rate of hospitalization of those who are 65 or higher. It's still a high rate, and we do have hospitalization even among our pediatric population. Here is number of deaths. So instead of rates, it's number of death and forecasting through the end of this month. These are predictions that were done, I believe June 8th was the cutoff for these predictions. Are the most updated ones that are on the website. But we are predicted to exceed 130,000 COVID deaths by the end of June based on this trajectory. And of course, you can see these gray lines showing the uncertainty based on what's happening with social distancing and how the spread may vary. I wanted to show this graph because this is a reporting that is normally done for pneumonia and influenza. And here, COVID is now added into that tracking. So it's pneumonia, influenza, and COVID mortality. And the reason that this is tracked is to help understand when we have outbreaks, usually of pneumonia and influenza. So against our seasonal baseline shown here in black. And you can see, this is the epidemic threshold. And here in 2008, we had an especially bad season of influenza and had an epidemic there. And you can see the height of that curve. Against that backdrop, you can see the current epidemic and how much higher this is. 7.3% of all deaths that occurred in the US during this past week, the week ending in June 6th, were due to pneumonia, influenza, or COVID. And of course, the vast majority of those were COVID. So that's this week right here. It's a much smaller percentage than up here, where 28% of all US deaths were caused by pneumonia, influenza, and COVID at the peak that we were seeing. But this is, really a very strong visual showing the impact on death, where COVID became the #1 cause of death in the US during this period. More than cancer, more than heart disease, it was the most common death during this period, which is really stunning. For the age distribution of COVID cases that we've had, again, this is in the US. Just to accentuate some of the things we looked about as rates before, here are a number of cases, but underscoring this distribution that we really are seeing COVID-19 cases across all age groups. We see that there's a much higher risk among older individuals, but there is a very large number of cases here among 18 to 64-year-olds because there are more people in the population among these ages and they're getting exposed. So while the severity is worse among people who are older or have comorbidities, the number of cases is actually highest in these age groups. Looking at the racial distribution, I'm sure you've seen or heard how much we're seeing racial disparities play out in COVID. It's of course very multifaceted. There is increased exposure because of racial minorities being more likely to work in sectors where they continued to work and not shelter in place. There are higher level of comorbidities in minorities that are compounding this situation. And then, there's really additional reasons that we're still exploring and understanding. But so here, looking by race, you can see a very high proportion of cases are Hispanic and Black in the US, more than half of all COVID cases. And we see 1.3% are American Indians, which is quite high for the American Indian population. 3.9% are in Asians. This shows the racial information as rates here. So instead of percents, it's observed as rates. So the highest rate is actually in Native Americans and Alaskan Natives. After that, followed by Blacks and then by Hispanics. The rate among Asians and whites is fairly similar, and these are age adjusted. So to talk about comorbidity, so among hospitalized adults, restricting to those who had information on medical conditions, which was the majority, more than 90% had at least one underlying medical condition. So we know that that is an important issue, that comorbidities clearly appear to increase the risk that this disease is severe and therefore you will be hospitalized. But it is important to also recognize the inverse here, that there are individuals with no comorbidities who also are hospitalized for COVID. Now it's possible they have an undiagnosed condition, but it's also, there are absolutely people without comorbidity that remain at risk and that have severe disease. In terms of the most common comorbidities detected in hospitalized COVID patients, hypertension, obesity, chronic metabolic disease, and cardiovascular disease are the four most common. I have some additional data on that here. It's a little bit hard to read, but green is the pediatric population and blue is the adult population. It's just showing the prevalence among cases of each of these conditions, and I've pulled out the most common ones here on the slide. Half of all adult cases had hypertension, and half of all cases had obesity. Both of those were in at least half of all cases. Metabolic disease and cardiovascular disease were in over a third of cases. Neurologic, renal disease, and asthma were in more than 10% each of adults. So all of these were somewhat common. But in terms of having no known underlying medical condition, 8.5% of hospitalized adults and 47% of hospitalized pediatric cases had no underlying medical condition. Here's the general guidance that the government is giving out about who is at risk for higher risk of severe illness. And I think it's always good to know what that messaging is and the level of data that we currently have. So on their website, they describe it as people who are at higher risk for severe illness, which they then, in a subscript, this is the groups that they identify: 65 years or older, people who live in a nursing home or long-term care facility, or people with an underlying condition, and they list those conditions that we talked about. They also have some other categories: people who are immunocompromised, people who have asthma, people who have HIV, liver disease, are all considered to be at higher risk for severe illness. I welcome any questions.
So, Dr. D'Souza, shall we proceed with the second talk and then we'll club the questions at the same time?
Sure.
Is that okay? Perfect.
Let me unshare.
Okay, Mahesh, you can take over actually.
Okay.
Can we unmute Dr. Allah?
Okay,
Perfect.
are you able to hear me, Sujit?
Yes, yes, we can hear you.
Thank you, Sujit. Thank you, the API executives, for holding such a wonderful series. I think it's educational for all. I will take the opportunity to introduce our second speaker, Dr. Joel Ernest. He is a professor of medicine and the chief of the Division of Experimental Medicine at the University of California. He did his medical schooling from the University of Nebraska and then proceeded to go to the warmer West, where in San Francisco, he's done his internal medicine, infectious disease, hematology, oncology. He has published numerous papers, given a number of honorary lectures, and has received an honorary doctorate from Sweden. He will be talking about the more positive stuff of COVID, that is the COVID vaccine candidates and what the future holds. Welcome, Dr. Ernest. I want to tell you that we share the Omaha connection.
That's right. Thank you very much. Let me have a minute to share my screen here. Okay, is that showing okay?
Yeah.
All
Yes.
right. So I thank you for the opportunity to speak and share at least what I can tell you so far about COVID-19 vaccines. So just some kind of warm-up information. So why are COVID-19 vaccines needed? What we've just heard, and I think what we know already, is that COVID-19, or the virus that causes it, SARS-CoV-2, is highly transmissible by the respiratory route. The disease is incapacitating and it's deadly. Importantly, as Dr. D'Souza mentioned, it can be transmitted by asymptomatic or pre-symptomatic individuals. And finally, I think an important point is that SARS-CoV-2 or COVID-19 can become an endemic infection. And I think one of the reasons to be concerned about that is that herd immunity or so-called community immunity is probably not going to be generated by natural infection. And the reason for that is that the basic calculations so far are that with the transmission rate of SARS-CoV-2, approximately 70% of the population would have to be immune in order to really arrest transmission of COVID-19 in a given community. And with a disease that has something on the order of an overall average mortality rate of 1%, that's really an unacceptable frequency that we expect to achieve. And so we really want to avoid the time where 70 or more % of people have actually become infected with this virus. And finally, it goes without saying at this point that the economic and the human impact of COVID-19 is huge. So let me see here. Okay. So a little bit of background about what we know or what we think we know about natural immunity to COVID-19. In other words, immunity that's conferred by becoming infected. Some of this is actually information that is just emerging now because of the newness of this infection. Some of it is based on precedents from SARS-1 and from MERS, which are caused by related coronaviruses. And so the first point is that protective immunity may be only transient after an infection. In other words, that unlike measles, smallpox, and other infectious diseases caused by other viruses that cause lifelong durable protective immunity, there's evidence that human immunity to coronaviruses is short-lived. In other words, that the immunity that's conferred by natural infection can wane in as little as a year. The second thing that I would say we think we know, partly from the precedents from MERS and SARS-1, but partly also really now emerging information from studies in experimental animals principally, is that neutralizing antibodies likely contribute to protection. I'll go into some detail about what neutralizing antibodies are and how they're generated in another slide, but just to introduce that idea. I think it's generally accepted that neutralizing antibodies are among the main goals of vaccination. However, the sheer or mere presence of antibodies, excuse me, doesn't guarantee protection. In other words, the assays that are now available and are becoming more and more widely available and used partly for epidemiologic studies, partly for community surveillance studies, those antibody assays only assay antibody binding to antigen. And they don't assay the quantity of the antibodies, and they don't assay the quality of the antibodies. And by that, I mean the functional properties of the antibodies. Excuse me. And to make the point, and so neutralizing antibodies are the ones we want, but those standard assays don't necessarily measure neutralizing antibodies. Another point to make, and I think this is a realistic concern, and that is to know that some antibodies can actually be harmful. In other words, there is a phenomenon that we know of from certain other viral infections, including probably the best characterized one is dengue infection. There is a phenomenon called antibody-dependent enhancement, where antibodies, depending on the way they bind to a virus and other properties of the antibodies, can actually accelerate internalization of the virus by cells, and through antibody binding to antibody Fc receptors on certain cells, actually the virus can enter cells that it wouldn't ordinarily enter. And some of those cells can then be major cytokine producing cells and contribute to morbidity. So it's really important that we have the right kind of antibodies. So moving on to vaccine topics, I just wanted to introduce the variety of approaches that are being taken to COVID-19 vaccines. And I'll show you in the next slide that actually there are quite a few efforts following each of these particular precedents. So the first approach is to use inactivated virus. In other words, this is a pretty straightforward process where the virus is grown in culture, then chemically inactivated so that it can't cause infection and replicate, but that it retains its immunogenicity. And I don't know if you can see my pointer here, but the point that I've made here is that this coronavirus particle here with the red spikes on it, the inactivation essentially modifies the virus so that it can't replicate. An example of this is the Salk polio vaccine, a very successful vaccine that was obviously used originally to control polio outbreaks worldwide, and is now actually the polio vaccine that's being used in polio eradication efforts. The second type of vaccine approach with a virus is to create or generate an attenuated virus, and that is to modify the virus that allows it to be infectious, but only able to undergo limited growth. And so in the cartoon here, the sort of virulent coronavirus is modified so that it's kind of pale and weakened so that it can't cause severe disease, but still retains its immunogenicity. There are many viral vaccines that we have that follow this precedent, including the Sabin oral polio vaccine, the measles, mumps, rubella vaccine, and various others. So these are very traditional standard approaches to making viral vaccines. They don't always work. And so because they don't always work, there are new technologies that are being applied, including to SARS-CoV-2 or COVID-19 vaccine development. There are two approaches using nucleic acid-based vaccines. The first is a DNA vaccine. This is an approach that's been around at least for a couple of decades, maybe a little bit longer, and starts with administration, generally parenteral administration of DNA that gets transcribed in host cells to RNA, and then that is translated to a protein antigen. So the person's own cells are making the viral antigen. And so we've got double-stranded DNA shown here, single-stranded, but conformationally folded RNA here, generating, in this case, the SARS-CoV-2 coronavirus spike protein. A similar but newer approach that we've heard a lot about in the news, actually, is an RNA-based vaccine where the DNA step is kind of skipped. The RNA is modified in such a way that injection of RNA is translated, is followed by translation to the protein antigen. And so again, host cells are the factories that produce the vaccine antigen and induce an immune response. So these are both really experimental. In other words, there are no currently licensed vaccines in the United States based on either DNA or RNA. They're still awaiting further trials. More on that in a little bit. Another kind of vaccine is the purified protein vaccine. In other words, that the purified protein antigen that's the target of an immune response, hopefully to generate neutralizing antibodies, is expressed, administered potentially along with an adjuvant, which is a chemical, generally naturally derived, sometimes synthetic chemical that kind of boosts antigen presentation and boosts the magnitude of the immune response. And so a purified protein is injected, generates an immune response, and that's also very familiar approach to vaccination. Diphtheria and tetanus toxin vaccines are good examples. A more contemporary one or more relevant one for viral vaccine is the hepatitis B vaccine that's widely used. A variant of that is preparation of so-called virus-like particles, or VLPs. And this has advantages in certain contexts where the purified protein is presented in a fashion that actually mimics a viral particle. And this approach is really used very, very successfully in the currently available human papillomavirus vaccine. The final approach is through so-called viral vector delivery of antigen. And we can talk about specific examples of this in the case of the COVID-19 efforts, but essentially the general approach is to take a virus that either is not a natural virus of humans or that is engineered and stitch in the gene for the antigen that you're interested in. So right here, the SARS coronavirus spike protein here is sort of stitched into an adenovirus vector. The adenovirus then is injected and used to produce the viral antigen, and both generally generates both T cell as well as antibody responses. So this is sort of the catalog of approaches to vaccine development that are being currently applied. So there are several goals of vaccine development. First and foremost is safety. We can't have vaccines that cause undue morbidity, certainly not morbidity that is, in excess of what the natural infection causes itself. It's also a very important point for popular acceptance of a vaccine. In other words, as you're surely well aware, a lot of people are fearful or concerned about vaccination and some of its impacts. There are certainly some unfortunate examples where fallacies were promoted and there were adverse consequences of that. So safety is extremely important. So I think, as I mentioned earlier, I think we generally think that neutralizing antibodies are desirable and probably essential components of a successful COVID-19 vaccine. So what are neutralizing antibodies? Here I've depicted an immunoglobulin G molecule. This is sort of the antigen binding domain. And what we want is to generate neutralizing antibodies that essentially bind to the spike glycoprotein of the virus and block the ability of the virus to enter our cells. And that basically is kind of a stoichiometric effect where we want to really saturate the surface of a viral particle. Now, in some cases, and there's evidence that humans infected with SARS-CoV-2 generate T cell responses. And T cell responses certainly can contribute to protection in several ways. One, they can make antibody responses better. And second, cytolytic CD8 T cells can lyse virus-infected cells and eliminate them. So what we want are vaccines that generate responses that block infection where the virus enters. Obviously, this is a virus that enters through our mucosa, generally respiratory mucosa. And so we would ideally like to block entry at that stage. We'd also like vaccines that generate long-lived immunological memory. One of the things that I mentioned earlier is that natural infection with the SARS-1 and MERS coronaviruses was transient. We'd like to do better than that with a vaccine. We'd like to generate long-lived, durable, protective immunity and immunologic memory. And finally, a very desirable property of vaccines would be that they generate responses that recognize viral targets that can't mutate and escape, like the influenza virus does and like HIV does. And so those are all sort of the goals of the efforts underway. Very briefly, here is a somewhat dated list, actually, of the number of groups attempting various approaches. So there are over 20 groups now working on DNA or RNA vaccines to COVID-19. There are about 24, a little over 24, working on viral vectored vaccines, most of them using adenovirus vectors because those got a fairly long track record. There are over 30 protein-based vaccines under development. Almost 30 of them are subunit vaccines, and about 5 groups are working on the virus-like particles that I mentioned. So I'd like to talk just a bit about the stages of vaccine development, because there's been a lot of talk about accelerating vaccine development during a global pandemic like we have with COVID-19. Right now, we're in this discovery or development stage. In other words, really trying things out, trying to determine in experimental animals what might be safe, what might be immunogenic, and what might generate protective immune responses. That's really the stage where we are right now. The next stage, and there's actually at least a small scale trial so far already reported in humans, and that is to address the question, is the new vaccine safe? And I talked about the importance of vaccine safety earlier, but again, this is really paramount, and I'll make the case that this is really something that can't be short-circuited or taken casually. The next stage is, does the vaccine stimulate immune responses in humans? In other words, you can design something that you think will work, but there's nothing quite like a human trial to determine, does this vaccine actually work like we want it to? Is it able to induce not only the kind of immune responses that we think we need, but also quantitatively strong responses? And so those are really the phases of vaccine trials where we are right now. There are safety trials underway. There are immunogenicity trials that are embedded in those safety trials. The next and important point is, does the vaccine protect humans from disease? In other words, that is termed vaccine efficacy. And that can be approached in a number of different ways that I'll mention in just a minute. And then finally, outside the context of an idealized, optimized trial with carefully selected subjects, does the vaccine actually protect humans in the real world? And that is termed vaccine effectiveness. So there are several other essential vaccine considerations, and I think they're particularly relevant in the context of COVID-19. One, whatever vaccines get generated and produced for COVID-19, they really absolutely have to be amenable to rapid, large-scale production. It's just not going to be good enough if you've got something that requires a lot of steps, that is complicated and expensive to produce. And that brings me to the next point, and that is, any vaccine that has any practical value against COVID-19 absolutely has to be economical on a global scale. We need billions of doses. We need to administer COVID-19 vaccines to billions of people. And so an expensive vaccine is simply not going to have an impact. Finally, for practical reasons, an ideal vaccine has to be stable. In other words, it shouldn't require refrigeration, or even worse, being frozen until its administration. Because as we all know, there are a lot of people who need to receive COVID-19 vaccines who are in less accessible places where the resources are less available. And certainly you need a regimen that can be administered to a community at large. So why does it take so long to develop a new vaccine? The simple answer is safety studies take time. You have to perform safety trials in a sufficient number of people and observe them for long enough to make sure that there aren't long-term consequences that happen in a small fraction of individuals. And so the last point, before we can go on to next stage or questions, is the question, can human challenge studies help? So efficacy studies ordinarily are done in a natural environment where volunteer subjects are vaccinated, another group is not vaccinated, they circulate in the community, and you compare the number of people that acquire the infection in the vaccine recipient group versus the control group. But in a case partly of a pandemic where the incidence of the disease is beginning to wane, that can involve very large numbers of people, and it can be slow and expensive. And so an approach like that could take several years to actually determine whether a vaccine is efficacious. Another possibility, another approach, is to use smaller populations of volunteers that are vaccinated and then experimentally exposed to the infection. This is the so-called human challenge model. This is much more rapid. It's much less expensive because it doesn't require such large populations. However, a major problem that we have with COVID-19 and considering human challenges in evaluating COVID-19 vaccines is that there is a huge ethical concern for human challenges when a reliable curative treatment is unavailable. So human challenges are currently being used, for example, in the development and evaluation of malaria vaccines. So volunteers are administered the experimental vaccine or a control, then they're exposed to malaria parasites and monitored very closely for symptoms of malaria. At the first symptom of malaria, they're treated. They've used drug-susceptible parasites, and so we know that we can cure drug-susceptible malaria. We don't have any drugs like that right now for SARS-CoV-2. And so this poses, I think, ethical as well as scientific challenges that I think there are a number of approaches to confronting. So with that, that ends my at least formal presentation. I'd be happy to take any questions that anybody has. Thank you.
Thank you, Dr. Ernst. That was wonderful. So our next speaker actually couldn't make it tonight because of a family emergency. So to fill in the gap, you know, the advantage of having an academician as a co-moderator, I have to fall back on Dr. Alla to give a little touch points on cardiology and COVID and just practical questions. But before he gets started, we'll take some questions from the audience and also some of the questions I'm sure from us also. So this first question that I have is herd immunity not achievable for COVID and why? I think Dr. D'Souza already talked about it, but maybe you can specifically.
I do want to, I know Dr. Ernst touched on it for a minute, but this epidemic ends in a few different ways. So the best way that the epidemic can end is that we socially distance enough to keep cases low until we have a vaccine, we vaccinate everyone, and we acquire immunity that way. But, you know, it's going to take another year at least to get a vaccine that works, I think, maybe longer, and then to scale that up and get people vaccinated takes time too. So we're not talking about something that's going to happen in the next few months. When we talk about that hope with the vaccine, I think we're talking about, like, you know, is that going to happen in the next 2 years, that could be developed, scaled up, and rolled out, you know, worldwide. That would be the best case. If we don't develop an effective vaccine in that time frame, what happens? So it really depends on what the population is doing, how much people are distancing and not. We absolutely are going to have additional waves of the infection. And if people don't distance as rates go up in their area, we'll get exponential growth with the outbreaks being pretty bad. When Dr. Ernst mentioned we don't ever want to get to herd immunity, we can't get to herd immunity with this disease without the vaccine. The reason so many of us say that is not that it can't happen, but the cost of human lives would be so high. So if there's never a vaccine for this, we would eventually get herd immunity, but it would be at the cost, again, of so many human lives. So all the social distancing measures are to buy us time, and already we have improved the therapeutic options that we have. And so it's not just to wait for a vaccine, it's also to figure out how do we better treat patients once they're severely ill and reduce mortality that way.
I'll take the second question, This is for Dr. D'Souza, and it's from Trivedi. Dr. D'Souza, what about chronic kidney disease? We talked about hypertension, obesity, and cardiovascular disease as risk factors. You know, you have a lot of moderate CKD patients.
Yeah, this is an area, I mean, understanding which comorbidities increase risk and by how much is still changing very much. We don't have a complete picture. The CDC does list individuals undergoing kidney dialysis as a risk group. They don't list kidney disease as was mentioned, but I've certainly heard elsewhere that CKD could be a risk factor and that we're seeing patients with that. So, you know, I think it's not completely understood yet.
And the other part of the question was probably not academic, but maybe a little bit more political it could get. There is a resistance to the second shutdown. So what are your predictions? Should there be no second shutdown? Is the second wave going to be much worse, or is it going to be about the same?
I'm sure we can both answer this. Let me take it first. What I would say is, we cannot stay locked in our houses forever, and that's not the suggestion. That's not the message that we give people, that they can never go out again. But the less distance we are and the less precautions we take, the worse it will be. So it's very much dependent on the local environment. But I think people need to develop a new normal, right? So where they have small groups of people that they are getting together with, when the rates in their area are not high. But it is the same people. We can't tell them that they can never have other individuals that they're hugging and seeing. But right now, when we've brought rates down in some places and people are going out to settings where there are dozens or hundreds of people and not wearing masks, we of course are very concerned. And we see the numbers rising in response. I think they're going to continue to rise. And we're going to begin to see hospitals filling. And the question is, what will happen as that second wave comes and as things get bad? The hope is that we won't have one system fits all for the country now. We will do it more localized. But again, people are starting to fly by plane again. So having local solutions only happens when people are not mixing, right? And that, you know, plane travel really did decrease dramatically. But, you know, if you look internationally, New Zealand had eliminated all cases. They were down to 0, and they just had 2 people fly in that were infected, and, you know, they've restarted their outbreak. Mm-hmm. So even though I'm saying to act locally, what that means is, you know, basing your level of social activity on what is happening locally, but with the consciousness that if the state next to you is having an epidemic much worse than where you live and people are driving between, that's going to come to your area.
Great. So the next question, I think, goes to both of the speakers. In your opinion, COVID-19 is it genetically engineered in the lab, or is it naturally originated from wildlife? If so, what is the mode of transmission?
I'd probably add to that question the question that came after as well. So if this is an animal virus, how and why did it make the jump to the humans?
So we're 100% certain that this is not a manufactured virus. That is misinformation that had been given out, that this was potentially a manufactured virus. What I have seen, I have not done this research personally, but it is very clear from the people who have studied this, that this was an infection that was in animals, they believe in bats, and then was transmitted. And that's happened with other coronaviruses as well. You'll remember in my talk, I showed that SARS and MERS were also coronaviruses that came also from bats. So we know that this kind of transmission happens, but they've actually molecularly looked at this virus and they can tell that it is not human-made. It is absolutely a naturally occurring virus. I don't know, Dr. Erst, if you want to.
I'd just add to that, I mean, to kind of reinforce it, it just didn't have to be engineered. It was engineered in nature. And, you know, it's, I think, very clear that bats were the origin. I think it's much less clear what intermediate host might have actually been the sort of link that allowed the modifications that made it into a virus not only capable of infecting humans, but also being highly transmissible.
That's great. So that's very reassuring to hear, because we keep hearing that, there was something that went wrong in the lab and things like that, but that's reassuring. So the next question is, if you look at different...
Could I just add one more thing?
Sure.
We're not smart enough to make something like this. I mean, nobody would know how to do it.
Okay,
So.
even if you want to. That's very good, actually. So if you look at the whole world, everybody is going through this. And then if you look at different countries, Sweden stands out, actually, because they took a stand that, hey, you know what? This is a little bit more sicker virus than influenza. Why can't we just protect our seniors and then let it run amok in the community, and the community will get herd immunity. Mm-hmm. And so I hear recently that Anders Tegnell came out and thought that, if he was given a second chance, he would have taken a different route. Mm-hmm. So do you agree with the Swedish approach of letting the herd immunity take over, or rather like not having strict lockdowns and things like that, like we've done in other countries, and US especially?
So, when this emerged, we knew that it was being transmitted person to person, and it appeared to have a severe mortality, but we were working with limited data, right? So some of this, you have to make the best guesses that you can at the time and continue to collect more data and evolve your response as you go. So initially, when Sweden took a very different stance than all the other European countries and Asian countries and the US, and really did not lock down the way we did, it did not seem like the right decision, but it was unclear. I think the evidence that has come out so far supports that although they had a lot of advantages, they have a high average socioeconomic status where they are more likely to have people living alone in large homes. They listened to the government, so the government knew there was trust in the government, and that if things got bad, they could switch, and if people respond. There were a lot of reasons why a slower response there might not lead to as severe outcomes as in some other places, but they saw much higher mortality than surrounding countries with similar demographics. It was still not as bad as what we've observed in the US, and that gave us pause, certainly. But the evidence to date really suggests that social distancing is what has, in fact, we know it's quite clear, it has saved a tremendous number of lives so far. What's not known is the end of this story. We've saved lives by social distancing, but if that, if we all now go out because of the terrible economic and social costs and have a huge peak this winter, then ultimately will our distancing in the fall have made a difference? Again, I think that the distancing, no matter what, has bought us time to improve therapies. And I am really hopeful that when rates go up again, people will again adjust their risk levels and distance again appropriately.
And again, Sweden has a much homogeneous population compared to United States, like, in terms
they have a lot of advantages, again, but the story in Sweden is not done yet. So they don't have herd immunity, right? This is not an infection that spreads, that they've finished with. So I think the ultimate end of their story is not yet known. We know that they are seeing a higher death rate than they would have otherwise, because comparing them to other countries around them that did socially distance, they have more deaths. Those are real lives, real people with real families that died, and they wouldn't have if the government had taken a different stance. But we now have to see the end of that story, is how long do those rates continue and what happens. Again, it's just, as physicians, but again, just remembering the individual lives and the individual people, it's a government's job to protect its people, and it's our job as public health and health practitioners to help people give the hard news that they want. So, we miss traveling and going out to restaurants and, you know, we all miss life the way it was. And the question is, what new normals can we do? And they don't have to just be Zoom based, right? We know that risk is lower going outside than inside, right? So, you know, going for walks with friends while weather is good, you know, what activities can we do that are not inside in large groups, and really getting people to rethink when they choose not to stay inside, which is safest, when they choose to assume risk, how can we help people do things that are lower risk?
So the next question is for Dr. Ernst, I would presume. So you've talked about a lot of candidate vaccines, but what is your best guess about the time frame when we'll have a real one available, realistically?
I think realistically, for a vaccine that we can have confidence in, that's at least safe and efficacious, boy, I'd like to be up. I think we're 18 months away, minimum of 12 months away. I think there are a lot of efforts to accelerate as many of the processes as possible. I think some of those are really interesting and admirable. I mean, industrial approaches, for example, generally they don't scale up production of anything until they know there's going to be a market for it. And in fact, in this case, there are efforts being incentivized for vaccine manufacturers to actually scale up, build capacity for production before they even know that they've got an efficacious vaccine. Now that will shorten the time between the knowledge that we've got the right thing and the ability to deliver that. On the other hand, it doesn't shorten the time that it's going to be required to know that we have a safe vaccine that's helpful. I think the other point is, I think we're going to have a lot of vaccines. There are a lot of efforts. I don't think there's going to be one single vaccine that stands out and, you know, is the vaccine that everybody wants for every patient, every person, at every age group, every risk group, every community. And I don't think that's a bad thing. I mean, going back to the polio precedent, it's 70 years later, we still have 2 polio vaccines. And they turn out to have interesting roles in different contexts where, for a time, the oral polio vaccine was the superior vaccine. Then we got to a point where it actually had more disadvantages than advantages, and we returned to using the injectable inactivated vaccine. I see a very analogous development happening with COVID-19 vaccines.
So I think the RNA-based is the Moderna, and viral vector-based is the Oxford. We keep hearing a lot about them. And then, I know, even to the point that by the end of October, we'll have some amount of vaccine for at least vulnerable people and healthcare workers. Because I read somewhere that, you know, phase 3 trial for Moderna vaccine has started. So what's your take on it?
I mean, obviously there's an enormous investment in both of those. And the Moderna vaccine looks promising on the basis of the limited data that we have. But there is no licensed RNA vaccine for anything yet. Right. And so it's uncharted territory. I'm not necessarily predicting, and I certainly don't want, some major surprise that we learn that an RNA vaccine is a lot more toxic than expected. I certainly don't want that, but I certainly don't have any data to say that it's not plausible. I think the Oxford vaccine is a different approach. It's a viral vector vaccine with a chimpanzee adenovirus, and there's a long explanation for why it's a chimpanzee adenovirus. I mean, that platform has been used for TB vaccine candidates, for malaria vaccine candidates, and maybe those are the 2 toughest targets, and maybe, but they haven't been very successful. So maybe this will be sort of the success story for that platform, but we'll see.
So the
On
next
the herd immunity point, I just want to circle back and let people know less than 10% of Americans we think have been exposed so far. Even in New York, we think it's like 25-30%. So again, I just want to make sure people, it's not that we can't get to herd immunity, but so many more people are going to need to be infected, so many more deaths to get to that number. In New York, already 1 out of every 500 New Yorkers died, and less than half of New Yorkers have been exposed. We think it's around 35%. So it's really, we're very far, very, very far from herd immunity. Most of us remain at risk.
Okay, go ahead, Mahesh.
The next question is about pediatric population. Which age group within the pediatric ages is more susceptible to infection, and what kind of severity predictions are there for them?
I don't know this one. Do you know that, Dr.
I can only tell you what I've heard. So my colleague George Rutherford, who is an epidemiologist and very actively involved in this, is postulating that the pediatric age group, let's just call it, is actually a group of people that will transmit less SARS-CoV-2. The original thought was that young people, children, pediatric patients, pediatric age group individuals are less susceptible to infection. They're probably more susceptible than originally thought. But it does seem as though transmission by pediatric age group is lower. So this then becomes really a mathematical question. In other words, is it low enough that you can let kids interact? I mean, we all know how difficult it is to have kids, comply with the sorts of things that we've all tried to implement to make things safer. And that's very, very hard with children. And send them to school, it's going to be even harder. So it may be that they are sufficiently poor at transmitting to one another and to adults that it's less bad to let them interact than for masses of adults to interact. I think that that's just emerging information. This is a topic that Dr. Rutherford just brought up within the last week and a half.
There have been schools that have reopened in Europe. I know initial data has been positive, suggesting there wasn't a lot of transmission, which is hopeful. And of course, there were preventive measures put in place. But, we are seeing, while lots of camps are closed, there are daycares and camps that are open in places in the US. And I think we'll have, hopefully, data from this summer to give us confidence going into the school year, with what we see with those camps and daycares that are open. And if there's not transmission happening, that will be, an encouraging sign, because we all want to find ways schools should be open in the fall. It's just, how do we do that safely? But we do know that the initial reports that kids could not get infected or could not develop COVID are wrong, because there have been absolutely some severe COVID cases in young people, and it's just unclear why. Most children have mild or no infection, and then some die even.
So if the schools get started again, do you envision that to be happening with the masks and distancing?
We really don't have enough data, unfortunately, to understand what the risk level is. My own personal belief is yes. I do think we need to find a way for schools to open in a distance and safe way, not school as it was before, because I think the risk is too high in the middle of this ongoing pandemic to go back to crowded classrooms with no preventive measures. I think that would not be just a smart move on our part. So I hope to see enhanced cleaning, enhanced spacing, and use of masks.
And there are novel approaches to kind of encourage school children to comply. There was something a couple of weeks ago about schools in, I think it was South Korea, where they had the school kids make hats that had projections that were 3 feet long. And so, if your 3-foot extension was touching somebody else's 3-foot extension, then you were 6 feet away, and that was okay. And they made it into a game, so the kids could make their own hat and all this other stuff. Now that's going to work probably up to a certain age. And then when kids hit adolescence, they become a little cynical, and that's probably not the game anymore. But I do think, there are probably, we shouldn't underestimate what can be done to encourage and incentivize school-age children to actually be as safe as possible.
So, Mahesh, do you want to take that next question here about the LA County thing?
Yeah, so a couple of questions. So one, I think if the second wave is going to come, especially with the winter coming, I think I can build two questions into one. I had this question: is this a virus that's going to have the winter peaks like the flu virus? Or is there that evidence so far? Number two, if the second peak is going to come, when are we predicting that second wave? Obviously, I think it will depend on the state.
Yeah, so there is not evidence that this is going to be a seasonally based virus. And that is when we look at other countries that were in cold weather when, during when this hit, we don't see any reduction or increase based on the temperature. So there's not a suggestion that it will be seasonal. But what does happen seasonally is flu will hit, which will compromise, once we have other respiratory illnesses happening, that not only will make COVID worse in those patients, right? If you're battling the flu and then you get COVID, it may be more severe than it would otherwise. But we also have hospital beds filled with, pneumonia and flu patients, and then COVID. So our hospitals are also more likely to be overwhelmed. Mm-hmm. So I think the impact of the epidemic could be worse during the flu season, even if COVID itself is not seasonal. We really don't know time-wise, right? When the second peak happens depends completely on our behavior, on how risky people are being and how they are mixing. And what we are seeing now is number of cases are increasing in more than half the states. Mm-hmm. So while many of us hoped that we would have a longer time between peaks, the current trends in the nation suggest that before rates were as low as we wanted them to be, things are beginning to turn around and increase, which suggests that second wave will come sooner than initial predictions. Mm-hmm. But again, it will depend if people halt their reopening plans, if they change their behavior and reduce risk, we'll see numbers come down. It is completely within the power of what we are doing.
We have a few more questions. Do you guys okay with hanging out for a few more minutes? Because I let Dr. Alla speak a few slides on cardiology, and then we'll come back. Hopefully we'll have a few more questions.
Okay, I'm going to share my screen. Are you able to see my screen, Sujit?
Yes.
Okay. So looks like I'm the misfit here among epidemiologists. I'm a cardiologist. I don't really know how it spreads, but we see patients when they come to the hospital. Because one of the speakers could not be here for a family emergency, I quickly put together some, what I would say take-home points for people who are dealing with these patients from a cardiologist's perspective. So what are the key cardiology controversies, consensus, questions? I think it all started with the antihypertensives. We all know that this uses the ACE2 receptor to get into the cell. So there was a lot of early publications on the potential risk of using ACE inhibitors or ARBs for treating hypertension. And as you guys already heard, hypertension is the most common comorbidity in these patients with a severe COVID infection. The second thing is QT prolongation and ventricular arrhythmias, and this all started with the treatment with hydroxychloroquine, chloroquine, and azithromycin, both potentially QT prolonging drugs, and 1 + 1 became 11 very quickly. The number 3 problem is elevated troponin, and we as cardiologists love and hate this. This is a test that I love and I hate as well, So elevated troponin is very commonly the reason we are called to take care of these patients. The fourth, fifth, and sixth are basically hypercoagulability that we came to realize after the first couple of months in these patients, young patients dying with PE, thromboembolism, arterial strokes, and then the issue of right ventricular failure in those with severe lung issues. And then if time permits, I thought I'll touch on the new modified protocols for acute MIs and stuff, but I suppose that we will not have time to cover those. So I'm going to touch on each of these controversies and what the consensus opinion of cardiology groups in America and the world over is. So the first comes to angiotensin. You know, as you all know, angiotensin receptor blockers, ACE inhibitors, are one of the most common drugs that we use. And my wife and a sister, who are both physicians, tell me the cardiologist is very easy job. You know, you give aspirin, Plavix, and you give ACE inhibitor, beta blocker, and that's statin. That's about it. 5 drugs, and you know cardiology. So, you know, it is a very common drug. So going through the slide here, basically we give angiotensin receptor converting enzyme inhibitor, which blocks angiotensin 1 becoming 2, and the receptor blockers block binding of the 2 to the angiotensin receptor, so preventing all the adverse effects. The ACE2 molecule actually is a counter-regulatory thing. The concern with this is it is the receptor, and it is technically believed to be upregulated in ARB use, not necessarily ACE inhibitor use, though there is a lot of controversy on that. When these are upregulated, so you presume that there is increased viral entry into the cells. So that's where it all started. I think the risk is generally overblown is what I would summarize briefly. A lot of studies have been now done, and there is convincing evidence that ACE inhibitors and ARB use doesn't make things worse for COVID-19 patients. In fact, a large study from China, about 1,100 patients, looked at patients with hypertension who are hospitalized. Again, this is not outpatients, but hospitalized patients. About a fifth of them were on ACE inhibitors and ARBs, and they did a propensity matched analysis and studied the 28-day mortality. The ACE inhibitors and ARB group had a significant lower mortality, so almost 67% lower than the group that was on different antihypertensives, even after adjusting for baseline risk factors. So, you know, this is very clear that, that they don't increase mortality, you know. Residual bias and all the statistical issues can still exist, but I think this is convincing proof that they don't definitely increase your mortality. So all the cardiology societies are clearly recommending continuation of heart medications, particularly ACE inhibitors, ARBs, unless, of course, they get severe enough where they can take antihypertensives. So I think the consensus statement is please continue those drugs. The next issue is the hydroxychloroquine and arrhythmias issues. And I think this is more of a political thing because it started before the science came out. So the earliest studies from China, which are small studies, pointed out that hydroxychloroquine could have a role in this. So it was an empirical trial and observational studies, and that was approved for, you know, EUA application by the FDA very early on when we were in March, you know. Now, you know, as you know, we have everything polarized these days, and this brought up the issue of was the FDA trigger happy in approving this. And very soon thereafter, there was a big study in Lancet that studied a lot of patients and said this increases death. So again, they were pointing fingers at the FDA and saying it was more of a political decision. And the FDA took a step back and just started saying, don't give it for prevention, don't give it for less sick patients, only use it in the hospital setting because of the risk of ventricular arrhythmias. So that was one step back. This is like a plot again in a movie. It takes twists and turns. And then there is this big retraction from Lancet of the same article that said there is arrhythmia risk. And this is authored by Dr. Mehra and his group. And the issue was about the way they harvested the data in this SurgiSpear database. So these studies were called into question. And now the people who are fighting to get the hydroxychloroquine withdrawn now we're questioning that evidence. But ultimately, I think we have enough data to to convincingly say that hydroxychloroquine doesn't seem to have a positive effect. Again, these are small studies, but much better designed studies. And I think it was the right decision to pull the plug on hydroxychloroquine. Even with our own limited experience in Nebraska, I had 2 patients with polymorphic VT that very early on I had to stop these drugs because I had no choice. So these risks of arrhythmia are real. And once we know that the efficacy is very limited, I see no reason for persisting with this drug. And so if you look at the first trial that's published in NEJM, it's a randomized study, but it's prophylactic for people with high-risk contact, and hydroxychloroquine did not work. The second study was, I think, from France, and they looked at patients with mild to moderate disease, and it was an open-label randomized trial. It did not work. All our New York data consistently say it doesn't work. And the same thing, I think this is a Chinese study. The last study is a Chinese study where hydroxychloroquine did not work in severely sick patients needing oxygen. So these are the sicker patients that are hospitalized with COVID. So I think I would summarize here by saying chloroquine doesn't work. The risks of arrhythmia are real. So the next question is troponin elevation. There's a lot of mechanisms by which troponin is elevated, the least of which is the real myocardial infarction. I think that's one learning point I want to make. Very few of these patients actually have real myocardial infarction the way we think about infarction. So most of these are probably because of the microangiopathy and type 2 myocardial infarction, or very intense inflammation that's driving myocardial injury, but not infarction. There has been some suggestion of myocarditis, and studies have shown that the myocardial cells in 35% at least carry the virus, particularly because of the ACE2 expression. But clinical myocarditis, fortunately, seems much less common. Again, there are a lot of patients with troponin elevations. Most of these are minor and not associated with MI. Significant elevations are definitely associated with poor prognosis, though they are not MI. Obviously, the people who have troponins frequently have comorbidities pre-existing. And once you have a high troponin, you know that they're at high risk for mechanical ventilation, ICU stay, and or overall death. What I've been doing is I do not recommend troponin routinely in these patients, though it's very hard for me to get that done, even in our own system. I would say don't order troponin unless there is a clinical suspicion of real ACS. There is an EKG change, or you're suspecting myocarditis, there is rapid hemodynamic deterioration. Because even when you have a troponin, you really can't do much about it because it's not real ischemia. Like I said, troponin elevation is very unlikely to be ACS in the absence of other evidence, systemic signs, symptoms, or EKG changes. There was one good but small study from Israel that studied systematically these patients, about 100 patients, and about a third of them have normal echoes. About a third to 40% of them have RV dilatation and dysfunction. And I think this is the major cardiac issue that we are facing: bad lungs, severe ARDS, and RV failure. That's been our biggest problem. About 20% of these people had troponin, but there was no correlation between the troponin and LV dysfunction, which was noted in about 10% of the people. So I think the troponin goes more with the RV failure and severe lung injury than true ischemia. So hypercoagulability, again, there's a lot of data that these people have high risk of thromboembolism, about 25 to 40%, multiple risk factors that we already know. And what I would summarize here is brief take-home points. Do not stop cardiac medications, particularly ACE, ARBs, or beta blockers in heart failure. Statins or antiplatelet agents in CAD unless there's obvious bleeding. Troponin elevation is often not indicative of ACS, so I would not put too much faith in that unless there's concomitant evidence of other cardiac issues going on. LV dysfunction myocarditis also seems somewhat rare despite the troponin elevation, and it's more often the RV dysfunction failure, so lung support is the most important element. So we should give extra attention to DVT prophylaxis, and in my own practice, I've been recommending kind of a higher dose of heparin or even 500 units, especially if they're on a ventilation, though they don't have DVT. It is 25%. If they have DVT, obviously you use the treatment doses, but even if they don't, I'm still nervous using the routine prophylactic dose. I kind of go back and forth, unless they have bleeding, of course. So I would say you should have a low threshold for anticoagulation. Obviously, make sure you refine all your protocols for EKG, echo, STEMI, and rhythm monitoring in these patients, and use the novel tools like remote monitoring and portable ultrasound, because I think that minimizes exposure. The risk of arrhythmias, I think we already talked about quite a bit. So hopefully with withdrawal of hydroxychloroquine, we won't see as much of this. I'll stop here so that we can take some more questions, and I'll be happy to answer anything pertaining to the cardiac issues.
Yeah, being a cardiologist, Mahesh, I think those are the essential key points. I think, it's a very good snapshot of take-home points, like, we can go home with. Thank you for that. And so there is one more interesting question that came from the audience. If probably the question goes more to Dr. D'Souza and maybe Dr. Ernst also. If you notice, the case fatality rate in US is around 5 to 6%, somewhere around that point. And you look at India, it's like 3 to 3.5% right now. So is there any difference? Do you think, is it a real difference, or is just that we need more time for more cases to come up in India? Is that a real possibility? That the case fatality rate is low?
Yeah, so I think we do not know yet, because there's such a big difference in getting into hospitals and being tested and confirmed to be COVID positive. So there are still huge denominator issues to these ratios, right? So case fatality completely depends. And in a lot of places, it's the most severe cases that we're getting in. So I don't think case fatality is going to be anywhere near 4 or 5%. Everything that I've seen has suggested it's going to be closer to 1%. But again, it really depends on what that true denominator is. And I don't think we know, since there are some asymptomatic cases, and we're not quite sure how much those are, it makes it difficult to know. So your question about differences in the fatality rate in India versus US, I think there's tremendous testing differences. There's not going to be a pathologic difference in the mortality. It's much more likely to be a diagnostic difference, a difference of who is in the hospital, and then potentially differences in, of course, obesity, other comorbidities, and treatment-related access could all influence. And age. India has a much younger population, of course.
Go ahead.
I was going to mention that if you didn't, because so we do quite a bit of work in sub-Saharan Africa where the mortality rate seems low, but the average age is also substantially lower than Italy or the United States, for example. So I think that may very well be a factor on a population level.
Yeah, I think the key thing is, people have to remember the difference between case fatality rate and, infection fatality rate, right? Because the people who get infected are not being tested. That means that can skew hugely. Based on a recent antibody trial, antibody study in LA County, it seems like the infection fatality rate is around 0.54%, which can be standardized to pretty much anywhere in the world.
So I'll take the next 2 questions and club them. One of the interesting questions was, kids have a lot of coronavirus infection, so is there some cross immunity? And in that same breath, somebody else also asked, what is the potential for this to mutate like the flu virus?
So maybe I can start with that one. It's the best answer is we don't know. I can talk about the mutation bit in a bit, but with respect to cross-reactive immunity, I think it's really an unknown, and unfortunately, we really kind of got caught with too little information prior to this. In other words, there were just no serosurveillance studies of antibodies to other respiratory coronaviruses that are really benign. They're upper respiratory tract. And so whether that is a mitigating factor in children, I think is just an unknown, and we may not be able to know it. In other words, it may be too late to find that out. With respect to mutation, I mean, SARS-CoV-2 is a RNA virus. RNA viruses are notorious for having a high mutation rate, but it's also very interesting because the polymerase, the RNA polymerase of the SARS-CoV-2 is a rare RNA polymerase that actually has proofreading activity. And so the error rate in SARS-CoV-2 is actually lower than it is in other RNA viruses. There is a large database that is being curated and shows that there really are a lot of mutations that seem to be random and that seem not to have a major impact on viral fitness. And I think I've been tracking that data fairly regularly. And one of the things that's pretty interesting is that the region of the virus that encodes for the spike glycoprotein is really quite conserved. And so if we make vaccines using the spike glycoprotein, particularly the so-called receptor binding domain, that doesn't look like it's able to be the target of mutations and still remain a fit virus. And so I think there are clearly mutations and there are clearly variants that circulate, but it's not clear that they're associated with differential virulence, and they may not be associated with the evasion of, for example, vaccine-induced immunity.
Sujit, I'll take a couple, 3 questions that are related to cardiology.
Sure.
So yes, somebody asked what are the cardiac meds that are in trial. Apart from fish oils, I am not personally aware of anything being studied primarily as a medication for COVID. A lot of studies on cardiac medication safety, but that's for pre-existing conditions. Yes, fish oil is being studied, and so far there's no data one way or the other. The other question pertains to statins, and I think I remain convinced there's no data on statins in COVID, but there's extensive data on COVID in flu, pneumonia, severely sick patients that statins have a mitigating pleiotropic effect. So at this point, I'm actually recommending statins to those who are already on statins. I'm not starting people on it, but I think there is a lot of background data to suggest statins could have a potential role in these people, especially if they have a pre-existing cardiac condition. As far as the antithrombotic therapy, I think I want to separate the evidence from my own personal feelings. So I want to separate that. Clear evidence that if you have COVID-related hospitalization, you should give aggressive DVD prophylaxis. I am actually in favor of doing extended prophylaxis. So there is some data that if you go out of COVID after discharge, you don't stop your DVD prophylaxis because these are people that are not really going out much. There is what I call the tail of the risk of DVD. So it happens even after you discharge for 3-4 weeks. So I've been proposing extended prophylaxis. So that's been my personal thing.
How about aspirin? How about aspirin?
Yeah, aspirin and the 10 milligrams of Xarelto. That's what I've been recommending.
A combination of aspirin.
Combination of those, yeah, unless they have high bleeding risk. Now, this is not data driven, but I think as far as they're in the hospital, strong data. Now, the other thing, if you have DVT, giving prolonged treatment 3 to 6 months, that's everybody agrees. The problem is in between. I see a lot of these patients who are in the ICU, they are on DVD prophylaxis, the 40 milligram sub-Q heparin, the Lovinox, but they're really bedbound, prolonged, very high D-dimer, very high, So even if they don't have DVT, I have been back and forth. If they have low bleeding risk, I'm saying give them 500 units of IV heparin like I do for my ABPs and stuff. Now, that's not evidence-based, but I've been more proactive in that. So I think more data needs to come in that basis. But I think clearly if they have DVT, you treat. If they don't have DVT, you give prophylaxis, but you extend it even after they go home. That's what I would recommend. For those people who are at home, I don't know what to do because you presume they're very mild and they're not sick. So when you first diagnose and keep them home, I think that's a gray area. I don't know if I would prophylaxis them, though I see some news reports that some people just drop dead at home.
So that's great. That's great. Very, very nice session, actually. Thank you. Thank you all. Thank you, Dr. D'Souza, Dr. Ernst, and thank you, Mahesh, for joining.
Thank you, Sujit. Thank you, everyone.
Thank you, everyone. Have a good night. We already are 5 minutes beyond the time, actually. So, but that's a good thing. Good problem to have, actually.
Thanks. Thank you all.
Thank you.